Good morning, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about hyperemesis gravidarum. So, what we wanted to discuss today, the definition, etiology, and the epidemiology of hyperemesis gravidarum, the pathophysiology, how to diagnose a case with vomiting with pregnancy and hyperemesis gravidarum. What is the differential diagnosis in such a case, and what is the complication? Lastly, the treatment and prognosis. Let us start our journey. So, hyperemesis gravidarum is intractable vomiting, very severe vomiting that occur during pregnancy, which leads to weight loss, maybe more than 5% of the patient weight, and volume depletion resulting in ketonuria and or ketonemia. In USA, it represents about 2% of all pregnancies. And we should differentiate between two important items: emesis gravidarum or hyperemesis gravidarum. Emesis gravidarum has another names like morning sickness or nausea and vomiting with pregnancy, and the emesis gravidarum. While the severest form of vomiting is called hyperemesis gravidarum, which affected the general condition. So please look to this table with the comparison between both. In case of morning sickness or emesis gravidarum, it is common, usually in the morning, in the early morning, improves about 12 weeks, so in the first trimester, localized to the first trimester, and not affecting the general condition, and improve with very simple measures. Okay, what about the hyperemesis gravidarum? It is less common, occurs during day and night, persistent after 14 weeks gestational age. It affects the general condition and usually require special treatment and maybe hospitalization. Okay, so what is the etiology of hyperemesis gravidarum? The real etiology is not known till now, but many theories try to explain this, and we'll go through this in the pathophysiology. But we should know some risk factors like increased placental mass in multiple gestation and in molar pregnancy cases, consumption of estrogen containing medication. If there is family history, the mother, the sister experienced hyperemesis gravidarum, so the possibility of occurrence of hyperemesis gravidarum is high in the pregnant lady. Psychological factors may play a role, and motion sickness, and if there is history of migraines. What about the epidemiology? We should know that 27% of women experience only nausea, while vomiting may be seen between 28 to 52% or maybe more of all pregnancies. So it is very common problem. The vomiting with pregnancy is very common. The incidence of hyperemesis gravidarum ranges from 0.3 to 3%, and it is more common in Western countries. What about the pathophysiology? We said that the exact cause is unknown till now, but there is some theories trying to explain why hyperemesis gravidarum happen, and we have three big theories: hormonal one, GIT changes, and genetics one. Genetics one is the most recent one, and there is many studies nowadays about this point, supporting the genetic factor. Okay, let us start with the hormonal changes. We have two hormones may be related to hyperemesis, HCG and estrogen. HCG reach its peak during the first trimester, and this is corresponding to the typical onset of hyperemesis symptoms. And there is correlation between higher HCG concentration and hyperemesis. What about the estrogen? Estradiol level increase early in pregnancy and decrease later, mirroring the typical course of nausea and vomiting in pregnancy. So, increase of estrogen early in pregnancy and decrease late in pregnancy, simulating what is happening in the course of vomiting with pregnancy. So, this is the hormonal changes. What about the GIT changes? There is relaxation of the lower esophageal sphincter, and there is increase in the incidence of gastroesophageal reflux disease during pregnancy, and maybe this is the cause for the nausea and vomiting. Okay, of course, this relaxation of the sphincter occur under the effect of the placental hormones like estrogen and progesterone. What about the genetic theory? There is increased risk of hyperemesis gravidarum in patient has a positive family history. Her sister was having the hyperemesis gravidarum or her mom, so the possibility of being affected by the hyperemesis gravidarum during pregnancy is considered. Okay, recently two genes, GDF15 and insulin growth factor binding protein 7, have been potentially linked to the development of hyperemesis gravidarum, and many studies nowadays running about this GDF15 and IGFBP7. So look to this picture, please. You can see the GDF15 in the decidual stromal cells and centers in the brain stem affecting, and this GDF15 and insulin growth binding factor protein, both of them related to three important items: the placentation, the cachexia, and the appetite. Okay, and nowadays the studies is running for the relation of these genes and vomiting with pregnancy. Many studies suggesting there is a strong relation, and GDF15 and insulin growth factor binding protein also, both of them increased in cases of hyperemesis gravidarum. There is correlation, positive correlation between both. So, what about the diagnosis of a case of hyperemesis gravidarum? First, you should confirm that the lady is pregnant. Then, identify the symptoms and the signs of severe vomiting and if complication present. Also, the associated causes of vomiting should be excluded, and it may be gynecological, surgical, or medical causes. Then, obstetric ultrasound can exclude the presence of multiple pregnancy or molar pregnancy. And you should do some investigation to identify complication of vomiting. Okay, so what about the history? You should know the gestational age of the patient, the gravidity parity, and any complications occurring in the current pregnancy. What is the frequency of the nausea and the vomiting? And you can do scoring for this. And if there is any intervention in medical treatment, you should know about it. If there is associated constipation, gastric pain, all of these should be known very well. Any investigation done also before. And you should know that the average onset of symptoms happens approximately 5 to 6 weeks of gestational age. So let us go to the examination. You should know the weight of the patient and do comparison between the previous weight before pregnancy and the future weight. We know that hyperemesis gravidarum associated with loss of weight more than 5% of pre-pregnancy weight, or maybe more. Then you examine the fluid status of the patient through measuring the blood pressure, which will be lowered. There is hypotension. Heart rate will increase. Mild rise in the temperature. The tongue is dry and coated, and the skin is dry and wrinkled. Sunken eyes, and the negative capillary refill test. Please look to this picture. You do pressure on the nail bed for a few seconds, then release the pressure. Normally, there is refilling of the nail bed capillaries in less than 2 seconds. If delayed more than 2 seconds, this means volume depletion. Okay? So the test may be negative in case of hyperemesis gravidarum due to the volume depletion. Then do abdominal examination and the pelvic examination, because if you found any tenderness may be related to another cause rather than pregnancy. So vomiting may be related to another cause rather than pregnancy. You should search for it. Okay, like appendicitis, for example, maybe abdominal pain and tenderness more in the McBurney point and so on, and rigidity in this area. Also, ectopic pregnancy may be defined during pelvic examination. There is pain and tenderness with lateral mobility of the cervix. Okay, then you measure the fetal heart rate, and you know that it is variable in rate according to the gestational age. So the criteria of diagnosis include vomiting that cause significant dehydration as evidenced by ketonuria or electrolyte disturbance, and weight loss more than 5% of the patient pre-pregnancy weight during pregnancy, and without any other underlying pathological cause for vomiting. Okay, so we diagnosed that the vomiting is caused by the pregnancy after exclusion of other causes. So what is the investigation needed? We know we wanted to do urine analysis to check for albuminuria, ketonuria, and the specific gravity which is increased. There is decrease in chloride, and we can test it with the Fantos test. Then ask for CBC and the electrolyte evaluation, sodium and potassium and the blood gases. Hemoglobin and the hematocrit is increased due to hemoconcentration in case of dehydration. Okay, then you ask for also kidney function test, serum creatinine, blood urea, which is expected to be increased if there is acute kidney injury due to severe dehydration, and also glomerular filtration rate expected to decrease if there is injury to the kidney, so we should avoid this. Potassium, calcium, and magnesium, sodium, and bicarbonate should be evaluated. Thyroid function test, especially TSH, lipase enzyme, and liver function test for any affection or complication as regard the liver and pancreas. Do obstetric ultrasound to exclude the presence of molar pregnancy or multiple pregnancy or ectopic pregnancy. Okay. You may need MRI to diagnose other causes like appendicitis and the pedicular mass as a cause of vomiting or other pathology in the abdomen. You need ophthalmoscopic examination because the retinal hemorrhage and the retinal detachment may happen as a complication of the hyperemesis gravidarum. Also, you may need ECG because the possibility of hypokalemia with ECG changes like prolonged QT interval or ST depression, flat T wave. As you see in the picture, this is the ECG changes of the hypokalemia, and this is by ophthalmoscope the retinal hemorrhage. So the differential diagnosis for other causes of vomiting during pregnancy and symptoms simulating the hyperemesis like gestation trophoblastic disease, multiple gestation, ectopic pregnancy, HELLP syndrome and preeclampsia, GIT pathology like gastroenteritis, gastroparesis, small bowel obstruction, cholecystitis, renal problem like pyelonephritis, ovarian problem like ovarian torsion. So, we can exclude gestational trophoblastic disease by measuring the HCG in the blood. It is very high in case of molar pregnancy. And by doing obstetric ultrasound with honeycomb appearance, ectopic pregnancy can be diagnosed also by ultrasound and by HCG level and using the discrimination zone. The patient will have abdominal pain, syncope, and vaginal bleeding. What about preeclampsia with characteristic symptoms with high blood pressure and proteinuria? But typically the preeclampsia and the HELLP syndrome occur late in second trimester or in the third trimester, not in the early pregnancy. Okay? GIT causes like gastroenteritis, small bowel obstruction, peptic ulcer, cholecystitis, pancreatitis, hepatitis, appendicitis, all should be excluded. And each one has its characteristic symptoms. Pyelonephritis and the urinary tract infection in general and the renal stones and ovarian torsion also included in the vomiting, and we can exclude by doing kidney function test, urine analysis, by other symptoms related to urinary tract infection or other complication like ovarian torsion, and by imaging also like ultrasound. Metabolic disease like diabetic ketoacidosis, hyperparathyroidism, hyperthyroidism may have also similar symptoms, and we can differentiate it from hyperemesis by clinical examination and by investigations. Psychiatric disorder like anxiety, depression also may result in vomiting. Neurological disorder like intracranial hemorrhage, so the tumor cerebri, migraine, venous sinus thrombosis, all of these can cause vomiting, but are likely to have associated headaches or neurological deficits, so we can exclude it clinically. Toxic ingestion also can cause vomiting. Myocardial ischemia may be a cause of vomiting, and you can exclude it by clinical examination and investigations. So, what about the scoring for vomiting with pregnancy? Okay, there is a score called Modified Pregnancy Unique Quantification of Emesis and Nausea, BUQE. score. What about this score? This score asks for 3 questions. So you should ask your patient about the duration of nausea during the day, the number of vomiting per day, and lastly, how many times have you had reaching or dry heaves without bringing anything up? I mean, how many times she tried to vomit but nothing come out. So this is the 3 questions: the duration of nausea during the day, the number of vomiting per day, and lastly, the number of trial of vomiting but nothing get out per day. And according to the result, you give a score to the patient. Is it 5 point or 4 point or 3 point or 2 point or 1 point? Okay. Then you categorize your patient. Is it mild nausea vomiting with pregnancy, or moderate, or severe? Mild if the score is less than or equal to 6. Moderate if the score between 7 and 12. Severe if the score is equal to or above 13. Okay, so you should categorize your patient, and this score really is very important. You will categorize your patient. Is it in the mild category or moderate or severe according to the score as you see in this figure. So what about the complication of hyperemesis gravidarum? There is maternal and fetal complication. Of course, there is in maternal complications, there is malnutrition, dehydration, vitamin deficiency, peripheral neuropathy, retinal hemorrhage, maybe convulsion and the coma, stress ulcer, Wernicke encephalopathy caused by thiamine deficiency, which is vitamin B1. Vitamin B1 deficiency in case of hyperemesis gravidarum may be complicated by Wernicke encephalopathy, and this is very dangerous and may be a cause of death or permanent disability. So it is very important. Or the complication may include renal failure also, or acute kidney injury. Sometimes there is strong vomiting causing esophageal rupture and pneumothorax, and there is reports about this in literature. Electrolyte abnormalities like hypokalemia can cause significant morbidity and mortality. Higher rate of depression and anxiety during pregnancy. What about the fetal complication? There is conflicting information regarding the incidence of low birth weight and the premature infants and the setting of nausea and vomiting in pregnancy. Of course, with a severe condition like hyperemesis gravidarum, there is many studies suggesting that may affect the baby in the form of low birth weight and the premature infant. There is no association between hyperemesis and perinatal or neonatal mortality. In very large study suggesting that there is no association between hyperemesis and perinatal or neonatal mortality. The frequency of congenital anomalies doesn't appear to increase in patients with hyperemesis according to large randomized clinical study. So, what is the treatment? My aim in treatment is to stop this problem, the nausea and the vomiting, also to correct the problems which occurred as regard fluid and electrolyte imbalance, metabolic disturbance, also to prevent serious complications. We said we have many serious complications like kidney injury, heart changes, encephalopathy. So I have many important complications I should prevent it. According to the American College of Obstetrics and Gynecology, nausea and vomiting in pregnancy guidelines include steps for treatment. You should start with the case. If the case is mild, you start with certain regimen, and if the case is moderate or severe, you give another medication, and you give the suitable drug according to the box score. So initial treatment in cases with mild vomiting, you start with just stop the multivitamins and keep only the folic acid supplementation. Ask the patient to take Ginger 250 milligram every 6 hours. Also, we can apply acupressure wristband, like in this picture. This is the acupressure wristbands. It is said to decrease vomiting and stop vomiting during pregnancy. This is the acupressure wristbands. This is the initial treatment. Then, if the initial treatment failed, you go to the first line pharmacological survey. Should include a combination between vitamin B6, which is a pyridoxine, and doxylamine. And this drug, this combination in the market is called Vomibreak, for example. This combination of doxylamine and the vitamin B6 approved by FDA and considered category A. So it is very safe drug. Up till now, it is a very safe drug and it is category A. And have a very efficient effect on cases with nausea and vomiting, and safe for mother and the fetus. We have, according to the American College of Obstetricians and Gynecologists, we have different regimen of this drug, pyridoxine and doxylamine. Either you give the patient dose 10 to 25 milligram pyridoxine with 12.5 doxylamine up to 4 times per day, or you give her pyridoxine 10 milligram and 10 milligram doxylamine up to 4 times also per day, or you give her pyridoxine 20 milligram and 20 milligram of doxylamine up to 2 times per day. Then, if the condition needs stronger drugs or the first line medication cannot stop the vomiting, so go to second line medication, which include antihistamines and the dopamine antagonists. For example, diphenhydramine 25 to 50 milligram every 6 hours orally, or prochlorperazine 25 milligram suppository every 12 hour rectal. Okay, so we have an example: oral diphenhydramine or prochlorperazine rectal suppository. So this is this medication, antihistamines and the dopamine antagonist, as a second line treatment. What if the patient continue to experience significant symptoms but without signs of dehydration? You should shift to metoclopramide and ondansetron. Metoclopramide in the market is called Brim, and ondansetron is called Zofran. Okay, you give it orally for the patient, or promethazine if controlling will and good. If not, and the patient complain now from dehydration with the vomiting because of the severity of the vomiting, So you should start intravenous fluid policies or continuous infusion of normal saline, and give also intravenous metoclopramide and ondansetron, so Brimbrane ampoule or Zofran ampoule or vial, or bromocizine, all of them given by injection with saline infusion. Okay, you should correct the dehydration. Also, electrolytes should be replaced as needed according to the results of the investigation: serum sodium and the potassium and bicarb and so on. You should give the patient antacid or histamine 2 antagonists like ranitidine 150 to 300 milligram twice per day, or proton pump inhibitor like omeprazole 20 milligram twice per day. As you know, the patient usually complain of gastritis and the reflux esophagitis. What if the patient is resistant and there is severe refractory hyperemesis gravidarum? You should give the patient intravenous or intramuscular chloropromazine, as in the picture here, 25 to 50 milligram, or methylprednisolone. This is a corticosteroid, methylprednisolone, 16 milligram every 8 hours, orally or intravenously. So this is in severe refractory cases. What about the fluid replacement? It is very important to know that we should do fluid balance between input and the output. In every case of hyperemesis gravidarum, you should calculate the amount of input and the output. Okay? Intravenous fluid resuscitation with or without electrolyte replacement should be prescribed as required. Okay? If there is deficient electrolytes, you should add it, like potassium, like magnesium sulfate. Okay? Consider early treatment with intravenous fluid for women with dehydration prior to the development of electrolyte deficiency. So, in cases with severe vomiting or associated with dehydration, if you started fluid therapy early, it is a good choice to give the patient fluids. You will control the case early. If dextrose-based solutions are used, don't forget that you should give the patient intravenous thiamine. Why? Because I wanted to prevent occurrence of Wernicke encephalopathy. Because if you give the patient glucose, and this is very important knowledge, if you give the patient glucose 5% infusion, while there is thiamine deficiency, which is a vitamin B1 deficiency, you will precipitate occurrence of Wernicke encephalopathy. So first, you should correct the deficiency in vitamin B1 by intravenous injection. Then after that, you can give dextrose or glucose 5%. Okay? This is very important to be known. We know that the fluid infusion reduce vomiting, yes, control the condition, and you can correct the electrolyte disturbance, yes, and you can prevent occurrence of dehydration, and if dehydration occurred already, you are managing it. In severe cases, if antiemetic and steroid therapy has failed, nutritional support via enteral or parenteral. So enteral or parenteral, as in the picture here, this is the enteral nutrition, and this is the parenteral nutrition. Okay? You may need both in severe cases to restore rehydration, correct electrolyte, and imbalance in electrolytes in this patient, and to maintain nutrition for the case. So it is life-saving. For example, for fluid, you may give during the day 2 liters of normal saline, 1 liter of glucose 5%, and don't forget to correct thiamine deficiency first before giving glucose to prevent Wernicke encephalopathy. You may need extra amount of crystallite equal to vomitus or and urine output per day. You may give sodium chloride, magnesium, and potassium according to serum electrolytes. Vitamin B1 and B6 should be given to the patient. Give sodium bicarb or ring lactate if there is acidosis or low serum sodium. Psychological assessment is very important in these cases. Depression and the associated mental distress may be present in your case, which complain of hyperemesis gravidarum, and you should search for this and with the first examination, and later on periodically there is psychological assessment, because these patients are very fragile and in stress, so the possibility of occurrence of depression and mental insult is high. By the way, psychological factor may be a risk factor for hyperemesis or may be a result of hyperemesis. So it is very important to evaluate the psychological factor. What about the diet? In severe cases of hyperemesis gravidarum, nothing maintained inside the stomach, so you should stop oral feeding temporarily and give fluids. Then regain oral feeding after 24 hours of cessation of vomiting completely. Okay? Before stopping intravenous fluid, start gradually oral food with dry carbohydrate food. Like what? Like biscuits and toast. Okay? Then give the patient small and frequent meals. Gradually, full diet is restored. Okay? This is according to the diet in cases with hyperemesis gravidarum. What are the signs? Like to this picture, this lady, when the patient improved, she will feel hunger, sunken eye disappear, patient look healthy, there is normalization in the pulse, blood pressure, temperature, urine output, disappearance of acetone from breast and urine, complete stoppage of the vomiting. So the general condition of the patient is improved. All these are signs of improvement. So, is there any indication for pregnancy termination? Yes, you may need this, but very rarely. Very rarely, if you can't control this severe vomiting and now complicated by kidney injury or hepatic injury or neurological complication, so there is a life-threatening condition now. And to save the life of the patient, you may need to do termination of pregnancy. So it is done rarely, yes, in uncontrolled cases with complication which is life-threatening. So look to this figure, please. This is to summarize the treatment of nausea and vomiting during pregnancy according to the scoring system of Buck scoring. If mild, the score is less than 6 or equal to 6. Try to be conservative with the patient, just modification of lifestyle, stopping of the multivitamins, small frequent meals, high carbohydrate and high protein but low fat diet, consumption of fluid with electrolytes between meals, adequate rest, give the patient Ginger 250 milligram every 6 hours. If not controlling, give the patient acupressure, wristbands. Also, give the patient pyridoxine and doxylamine, like vomit break drugs, 10 milligram pyridoxine and 10 milligram doxylamine. If controlling the condition, you can shift to, it's okay, very well and good. If not controlling and persistent to be vomiting, you can add metoclopramide, ondansetron, which is brimbrane and zofran. If controlling the vomiting well and good in moderate cases, if shifted to severe cases, you should add another drugs like chlorpromazine, like methylprednisolone. In severe cases, you can add these drugs, and also you give fluid replacement therapy and the correct electrolyte disturbance, and you may need enteral beside parenteral nutrition also in some cases. So this is the strategy according. Is it scoring 6 or below 6, or moderate and score 7 to 12, or 13 or above, which is considered severe nausea vomiting with pregnancy or hyperemesis gravidarum. Okay, so you start with easy measures, then reaching the all effective drugs in severe cases at the end. So what is the prognosis of a case with hyperemesis gravidarum? We should know that nausea and vomiting in pregnancy is a common problem. All of us know that, and constitutes about 50% or more. Symptoms usually begin period to 9 weeks gestation, and the majority of cases are resolved by week 20 of gestation. A minority of patients, approximately 30%, will continue to experience vomiting during the third trimester. Approximately 10% of patients with hyperemesis gravidarum will be affected throughout the pregnancy. So only 10% of patients with hyperemesis gravidarum will be affected throughout the pregnancy. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.